I'm going to advocate, in my experience, to think about an ask, advise, and refer, or an ask, advise, and connect model, which is, for me, essentially the same thing. Asking, you identify tobacco use with structured assessments. Advising, this is where clinicians across the entire spectrum of care need to have the same message. Every clinician should say, hey, listen, tobacco is bad, and your cancer treatment, is going to, the best chance of you getting a successful cancer treatment is to try and quit smoking. That's what you can do to try and make things better. If you don't know how to quit, that's fine. Say, I have no idea how you're going to quit, but we got a cessation program to help you quit. Or we're going to give you access to this. I have no idea how you're going to quit. We're going to use this program. Ask them how they're doing. How are you doing with your quitting? Or how are you doing with smoking? And if they've reduced, say, great job. Don't criticize them for continuing to smoke. Remember, this is a systemic addiction that started when they were 14 years old and they got cancer. It is hard. Congratulate progress. Connect them to a cessation support. Additional considerations to think about, okay? And this is something that you have to buy into. I know how we are, and I'm happy to help with these types of things. How do you synergize a research message with clinical delivery? There are huge research questions coupled with clinical effectiveness with regards to tobacco and cancer patients. Consistent documentation and assessment, efficiency, try and coordinate across lots of different centers, and then message with a clear vision. Tobacco's bad. This is something you can do to try and make your cancer treatment better, and we are in this together. And I like to emphasize that we are in this together. Get your clinic to buy in, your receptionists, your technicians, all nurses, physicians, administrators, buy in. This needs to be updated, but I want you to realize that when you think about tobacco in cancer patients, you've got the biologic effects, the clinical effects, tobacco cessation. I used to have population, but really tobacco cessation-related things. And then we are being pushed more and more into the cost variables associated with this. The facets associated with tobacco use in cancer patients are significant. Don't just think of it as smoking, they don't care, we're not going to provide cessation support. Right now, this is possibly one of the best opportunities we have to improve cancer treatment as a whole.